Hi, I'm Rich Daly, and this is Fast Finance, your quick hit of the news and numbers that matter the most in healthcare finance. Up first, weird numbers. Today's weird number is 3.8 billion. That's the total drop in clinical laboratory fee schedule Medicare payments from 2018 to 2020. That's according to estimates from the American Clinical Lab Association. Now for today's main story. Medicare Advantage enrollment growth has slowed to its weakest in 15 years as both payers and providers pull back from it. MA enrollment as of April 1st increased by only 2.4% from April 2025. That's according to an analysis by Mark Farrer Associates. That was down from a 9.7% increase in enrollment back in 2021.
We're starting to see a slowdown and a stabilization of that growth because there is so much MA plans participation out there.
That was Sean Stack, Director of Healthcare Reimbursement Consulting for Forrest Mazars. Other MA trends to know include 6 of the top 10 Medicare Advantage companies had year-over-year 2026 enrollment declines. Elevance had the biggest enrollment drop, losing 15.8% of membership, while Humana added the largest number of new enrollees, or about 1.3 million. 43 states increased enrollment, and that was led by Texas, and 4 states had enrollment declines of more than 10,000 enrollees. Another payer trend is to shift more enrollees from PPO plans to HMO plans. The prior approvals required for specialist visits in HMO plans are another way MA plans will aim to control their costs amid worsening finances. This year also has seen more hospitals and health systems terminating Medicare Advantage plans.
More and more, we're hearing from clients and different hospitals that if they can't reach an agreement for an MA plan, they're more apt to get out of the contract because of issues in negotiations. And I think a lot of that has come from the ability to accept patients out of network and still get that qualified payment amount that was readily made available under the No Surprise Act. And more providers are taking advantage of being able to secure that qualified payment amount. So I do think that's a leverage point that hospitals are certainly exercising more.
Hospitals may get some prior authorization relief next year when CMS will require the use of the HL7 Fast Healthcare Interoperability Resources-based Application Programming Interface. However, that mouthful of a streamlining effort will work only if provider electronic health records and operational teams are ready to use that new electronic prior authorization infrastructure.
And my fear is that hospitals, this has kind of gone under the sight of vision line here for hospital leaders because it was pushed out as a CMS interoperability rule and prior authorization final rule for MA plans. So hospital leaders should not wait until 2027. They should start prepping IT, revenue cycle, utilization management, and case management teams now for these changes because it could be big for the industry and it could actually be one of the few wins that we see under MA plans in the next couple of years.
Stack said that he is hearing more hospitals and health systems engage in aggressive value-based payment arrangements with MA plans. However, those are still sparse due to concerns over timely data. Expanded use of AI to provide rapid data turnaround with less administrative burden and cost could boost interest in such arrangements.
I know this sounds like a broken record, but based on AI and advanced analytics technology, we can get this data much quicker now with much less administrative burden and cost, more timely to make sure that our clinicians are aware of the risks that are out there that are hurting them in performance. So personally, I do think this is an area, I think value-based care, quality outcomes, that type of contract design is going to increase in the next couple of years just because of the enhancements that we've seen through advanced technology.
All that means health systems may have options to improve their financial performance with Medicare Advantage plans, short of terminating those contracts. And now, before we go, just one more thing. Policymakers are using research that inaccurately concludes hospital price caps do not hurt the finances of those organizations in order to justify the ongoing spread of such policy, says a hospital strategic advisor.
People are using operating metrics that conveniently make the argument that hospitals are highly profitable in those states. And in most cases, that is not the case. And, to push back and say, well, hey, look, here's what we're actually doing. Here's our expenses. I think that is a political challenge. It's a communications challenge.
That was Jeff Goldsmith, president of Health Futures and a longtime healthcare industry analyst. That communication challenge is one hospital leaders will need to embrace to counter the proliferation of hospital price cap legislation across states. Such legislation is being bolstered by the kind of research findings on existing price cap laws that Goldsmith's raised concerns about. Well, that's all we got for today. Don't forget, you can get your Fast Finance newsletter delivered right to your inbox every Wednesday. Sign-up info is in the show notes below, or you can go to hfma.org. I'm Rich Daly. Thanks for listening.